Heart failure is a syndrome. It means that it has symptoms, what the patient feels, and usually those symptoms are related to functional limitation in terms of quality of life and congestion. Signs are what we see in terms of physical examination, and you're going to see signs usually of congestion. That means pulmonary congestion, lower extremity edema, and those kind of signs that tell us that the amount of extracellular fluid of the patient has increased. Also, complementary tests are going to allow us to assess an objective degree of cardiac dysfunction. And very importantly, we have to be mindful that heart failure is associated with increased morbidity and mortality. These two domains, really the syndrome with the symptoms and signs and the outcomes, are important to keep in mind when we are going to be talking about therapies. We have some therapies that are really very effective in treating the signs and symptoms of congestion, but really have not been shown to increase survival or to decrease hospitalizations. And I have, for example, diuretics. Other therapies of heart failure directly impact mortality. For example, beta blockers, angiotensin converting enzyme inhibitors are those two key players that are going to increase the survival of our patients. The AHA heart failure stages give us an emphasis on the continuum of heart failure. And we have patients that are at risk, for example, patients with history of hypertension that are at risk of developing heart failure, but they don't have symptoms of heart failure, and they don't have structural signs of cardiac dysfunction. Filling pressures are normal. The echocardiogram does not show evidence of left ventricular hypertrophy, for example. On the other hand, we have patients that may have signs of a structural heart disease, for example, decreased left ventricular ejection fraction, but no symptoms. For example, this morning, a few moments ago, one patient, she's a florist, she works really hard, she's going to the gym, no symptoms, her ejection fraction is around 40%. Stage C are the patients which are going to refer as symptoms. They're going to refer as functional limitations, and obviously they have evidence of a structural heart disease. Stage D are those patients that even they have symptoms after we were trying to optimize medical therapy, device therapy, and even after doing all those things, they are persistently symptomatic. In those patients, we should consider referral for the Advanced Heart Failure Center. Please let me know if there are any questions. Heart failure is really an epidemic, and the numbers in the most recent 2018 statistical summary from the American Heart Association are really, they speak for themselves. There are approximately 6.5 million of Americans with heart failure, and the projections show that this is going to increase to almost 46%, and more than 8 million people are going to be affected between 2012 and 2030. It's the most frequent reason of admission to the hospital in patients that are 65 years old or older. And each year, around 1 million patients are discharged from our hospitals with a diagnosis of heart failure. Heart failure is a deadly disease, and we have to keep in mind. That's why it's very important that we keep that in mind, because also we know that we have very effective therapies. After being hospitalized with heart failure, the 30-day mortality is approximately 10%. At 1 year, it's going to be 22%, and at 5-year mortality is 42%. So the survival has improved over the years, but still the mortality is very high. How we diagnose heart failure. And again, we have to keep in mind that it's a syndrome. And we're going to start, as always, with the history. And really, we have to keep in mind that for a trained healthcare provider, really their gestalt is the most important thing. But we have to be mindful there are certain items in the medical history that are going to help us to really increase the likelihood of that patient that is presented to us have a diagnosis of heart failure. For example, atrial fibrillation, history of cardiac CABG, myocardial infarction, diabetes, coronary artery disease. All those items really increase the likelihood of the patient having heart failure, and the provider should be mindful that they are not minor. Regarding the symptoms, really, I think there are 3 main domains of the symptoms, basically the shortness of breath, fluid accumulation, and arrhythmia-related symptoms. Shortness of breath is really one of the key factors, and really we have to ask the patient, when does that shortness of breath occur? This is related with exertion. It's when it's lying flat. This is orthopnea. After sleeping a couple of hours, the patient wakes up with severe shortness of breath, and this is paroxysmal nocturnal dyspnea. And also, interestingly, in the last 4 years, a new symptom has been described, basically shortness of breath when the patient is bending forward, and this is called bendomnia. Also, we have the patient tell us issues with leg swelling, increasing abdominal girth, early satiety, and also patients with cardiomyopathy and related conditions can have symptoms such as palpitations and syncope. When you're evaluating a patient with heart failure and the patient tells you, I have shortness of breath on exertion, it's extremely important to take time and try to assess the degree of functional limitation. When the patient can be class 1, really there are no limitations at the ordinary physical activity. But remember, what is ordinary for a patient may be not the same for the next patient, and we should be mindful of that, because we need to ask the patient how heart failure is affecting him. How is there any changes? For example, last year I was able to, I don't have any symptoms now, but I don't feel like going to the gym anymore. I feel like staying home, and those kinds of really questions are extremely important, because we want to know if there is any progressions of the patient is really limiting himself to try to decrease the burden of physical activity that triggers those symptoms. So remember, take time, assess the degree of physical activity that your patient is able to do. Try to figure out if the patient is trying to limit the amount of physical activity that the patient is doing, just to avoid having symptoms. And that is extremely important, because the New York Heart Association classification. You're going to be able to classify 1, 2, 3, and 4, and that's really directly linked to the to survival. The classification of the American Heart that we reviewed a few slides before, really A, B, C, D, is static. This means that once the patient has developed symptoms of heart failure and has a structural heart disease, the patient is classified as stage C. That same patient who was symptomatic and has shortness of breath on exertion at less than ordinary physical activity that, for example, performing the activities of daily living, such as cooking, doing house chores, developed this symptom. The patient was class 3, but we treat the patient. For example, we give diuretics. The patient can be class 2 or 1. So the bottom line, the AHA classification, that patient is going to still have functional class stage C, but the functional class can improve from 3 to 2 with treatment. Okay, so it's dynamic. Is that clear? Okay.
So yeah, so everybody knows, I do have your lines unmuted because everybody's pretty quiet. So if anybody wants to speak up or chime in, feel free to just unmute yourself and speak.
Yeah. So I know that everybody's familiar with the symptoms of orthopnea, paroxysmal nocturnal dyspnea. I just wanted to bring this new symptom so the persons can be aware and try to evaluate this, because really when you start asking about this bendopnea issues, you will be surprised of how many patients with heart failure have this symptom. And this symptom basically is evaluated by, basically you ask the patient to bend forward, and if it develops a shortness of breath within 30 seconds, that's considered bendopnea, and that symptom is associated with higher filling pressures, meaning right atrial pressure and pulmonary capillary wedge pressure. On physical examination, where we're going to be looking for to make the diagnosis of heart failure, really is obviously you can have a gallop, and that's very specific, but the sensitivity is low. You're going to try to do a neck examination, trying to assess jugular venous pressure and try to really quantify the jugular venous pressure. You're going to try to evaluate the patient for the presence of lower extremity edema. The same physical examination can be used to really assess, give you important prognostic information about the patient, and really in several large center clinical trials and registries, the presence of jugular venous distension has been associated with increased mortality. Systolic blood pressure less than 90 has been associated with increase in hospital mortality. And any heart rate increase above 70 has a linear increase in cardiovascular mortality and heart failure hospitalization. So these parameters I just mentioned, to be mindful and try to, they are not minor. Also, when you're doing the physical examination, you're going to find other physical signs related to potential causes of heart failure. We go to review some basic findings, but we already discussed the history, physical examination. Chest X-ray is extremely important. Basically, you're going to look for cardiomegaly, like one of our patients here, and you're going to try to evaluate if it's degree of pulmonary edema or not. That's not very specific in acute heart failure. We have patients with chronic heart failure. That's chronic adaptation of the lymphatic pulmonary drainage can lead to minimization of pulmonary congestion, but signs such as cardiomegaly, pleural effusion, really you should be looking into that to make the diagnosis. The EKG is extremely important. They check the rhythm. The presence of atrial fibrillation increases the likelihood of heart failure. Look for the presence of Q wave in ischemic cardiomyopathy. left-handed branch blocks, like in these patients, are important to keep in mind because they are potential targets for device therapy, and really the EKG is the very important tool in the initial evaluation. Then we are going to use laboratory data, and really we're going to emphasize the use of natriuretic peptides for the diagnosis of heart failure, which is a class 1 level of evidence A in current guidelines. We're going to use for prognosis, we're going to use brain natriuretic peptides, troponins, we can use that. And also we are going to be evaluating related conditions and things that are going to alter the way we treat our patients, and like parameters of renal function, the presence of anemia, liver function test, and thyroid hormone levels. Natriuretic peptides, really, it depends where you work, and usually these are small peptides that are secreted by the myocyte in response to increased wall stress, and usually this is related to increased filling pressures. The brain natriuretic peptide is going to be synthesized like proBNP, and the proBNP is going to be split by the enzyme, the corin, into brain natriuretic peptide. That is the active metabolite with a half-life of 20 minutes, and is an active component. Sorry for the mistake in the slide, but it's the active component, and it's a substrate of neprilysin. This is important to keep in mind, because if you have a patient that you're monitoring heart failure with that is on a neprilysin inhibitor, you will rather use NT-proBNP than brain natriuretic peptide. What are the effects of the natriuretic peptides? And this is related more to a little bit later. We're going to talk about the therapy. It's related increased diuresis, vasodilatation, renin, angiotensin, aldosterone axis inhibition, and sympathetic system inhibition. So they play an important physiologic role. But now we're focusing really in the ability of these peptides to help us diagnose heart failure. And this is, along with the history, physical examination, EKG, X-ray, key to order this test in order to assess if the symptoms of our patients are probably related to heart failure. On the other hand, NT-proBNP is not a substrate of neprilysin, has a half-life of 2 hours, and has a renal excretion, and that's why usually you're going to see increased levels in patients with renal failure, and it's inactive. Keep in mind that these important biomarkers are really non-specific of heart failure, so you have to be mindful that could be cardiac and non-cardiac causes of brain natriuretic peptide elevation. This is the non-cardiac causes are anemia, renal failure, pulmonary hypertension, critical illness, sepsis, and even severe burns. And then you have cardiac causes, and you're going to be causes like, well, acute coronary syndrome, valvular disease, and this is important in the sense to keep in mind of atrial fibrillation. Patients with atrial fibrillation tend to have a higher level of brain natriuretic peptide. As we discussed before, atrial fibrillation is per se an independent risk factor for the development of heart failure. So there's interplay there, but just to keep that in mind. Then we're going to discuss the echocardiogram. And really with the echocardiogram, for the purpose of heart failure, I would say there are 3 things that we want to look into. One is the left ventricular ejection fraction. And I want to make a small parenthesis here. When you're reading the report of, say, a left ventricular ejection fraction, keep in mind that it's in the loading conditions in terms of the blood pressure of the patient when that ejection fraction is recorded is important. It's not the same. You can say, well, my ejection fraction decreased from 50 to 40%, but the blood pressure was 170 over 100. So that's the ejection fraction is sensitive to loading conditions. Then keep in mind, observer, operator is operator dependent. So it's estimated approximately like 5% different in ejection fraction is going to be a given. So that small variation, the patient, well, it was 35%, now it's 40%. Really, is not so meaningful, okay? Keep in mind in patients that have a very irregular heart cycles because of atrial fibrillation or frequent PVCs, sometimes it's very difficult to evaluate the ejection fraction. The ability to give a good ejection fraction is going to be strictly dependent on the quality of the images. So you need good visualization of endocardial borders, and you need to be sure to avoid foreshortening, which basically is if you're cutting the ventricle in a smaller than really is, the ejection fraction is going to be looking better, okay, than it should. Then you're going to see the degree of left ventricular size and wall thickness to talk about hypertrophy and which type of hypertrophy are we talking about. Usually, patients with hypertensive heart disease and heart failure will preserve ejection fraction. The walls are thick and the cavity is small. Dilated cardiomyopathy and the contrary is going to look like the damages are going to be large and the wall thickness could be preserved or decreased. The other factor is going to be the valve function. The valve function basically see if there are any hints that the valve dysfunction could be causing the symptoms of heart failure, especially, for example, aortic stenosis. In aortic stenosis, afterload mismatch can lead for a ventricle to look thicker than really is by having inappropriate loading. And this inappropriate loading really is one of the things we have to be mindful when we define heart failure, which that's one of the things that we can potentially target and really improve the symptoms of our patient. There are other things that you can look in the echocardiogram and Doppler and really, is saying filling pressures, pulmonary pressures, and, you can use other modalities like a strain. But really, I think these three parameters are the one, when you read the report, try to see how the ejection fraction is, what is the size of the ventricle, is there any hints of valvular dysfunction. How we calculate the ejection fraction. So basically, it's the end diastolic volume minus end systolic volume divided end diastolic volume multiplied by 100. This sounds very easy and really is very conceptual, but usually we use mathematical formulas and modeling to get to these volumes. So there can be a mistake in any of our pictures of the way it can be extrapolated to this formula. The use of 3D echocardiography, when available, and the sonographers and the physicians are proficient, and the use is not recommended. By doing that, we can get real volumes from the echocardiogram. So really, I wanted to show you a picture of a patient really with severe systolic dysfunction. This means that the ejection fraction is reduced. And if you see in this patient, really we're seeing this ventricle is dilated. It's almost like 8 centimeters dilated. Normal is going to be less than 5 or 4.5. The thickness of the wall really is not increased. And if you see, this is the aortic valve. which is opening in the ejection, and this is a mitral valve. But if you see in each heart cycle, there is not much variation. This view is called parasternal long axis. From the same patient, if we go for the 4 chambers, and here we are seeing the left ventricle, right ventricle, mitral valve, tricuspid valve, left atrium, right atrium. And when the mitral valve is opening, this is diastole. And we're seeing that during the cardiac cycle, the left ventricle is not moving much. This patient has heart failure, has reduced ejection fraction. Then this is a spontaneous contrast. We're not going to be discussing that, but the concept is this patient has reduced ejection fraction, okay? We don't know if the patient has symptoms or not. In this case, I'm sure that he had symptoms and not the patient, but this is what the echo is able to tell you that has a reduced ejection fraction. It's not telling you, well, the New York Heart Association you already have from the history is not telling you, hey, which stage is of the American Heart Association is, because obviously, at least it's a B, but could be a C or even a D. We don't know, okay, by just an echo. So the echo's one part is very helpful and really drives the treatment in our guidelines, but it's a study that has to be put in context by the clinician who's seen the patient, who's getting the history, who's getting the physical examination, and who has other parameters of an organ function. Very good. Let me know if anybody has any questions, okay? We use the left ventricular ejection fraction to classify the type of heart failure. And really, the number is to classify a patient with heart failure with reduced ejection fraction is less than 40%. And this is kind of standard. It's not so easy, but the bottom line, why we use this 40%? Because this 40% is what was used in the majority of trials that show the benefit of medical therapies in heart failure. So this is the group really where we have the strongest evidence to treat our patients. This is the group where the pragmatic large trials were done, and really that's the way today we have our guidance. Patients can have an ejection fraction more than 50%, more than equal to 50%, and they have symptoms of heart failure. These patients have heart failure with preserved ejection fraction. In the middle, we have patients with an ejection fraction for 41 to 49. This is heart failure borderline. And really, this is a group where active research is ongoing to try to figure out which is the best way to treat these patients. Again, keep in mind that an error of 5% in measurements of ejection fraction is not infrequent. So we have to be careful when we are following a patient. And usually, ideally, you should have your echocardiograms done at the same place every time, so that it's easier to compare and assess if that change is product of a real change or there are some methodological factors involved. There are some patients who have reduced ejection fraction, okay? But after treating those patients, the ejection fraction improved to more than 40%, and this is heart failure with improved ejection fraction. For these patients, really the consensus is to continue to treat with the same medications that they were treated before to get that improvement. The caveat of this is, we can say, well, if there is a condition that was reversible and that was treated, the patient had, aortic stenosis and was treated and the ejection fractions improved, so do we need to continue the neuromoral blockade? We can discuss that. The patient was diagnosed with a pheochromocytoma and the pheochromocytoma was removed. We can discuss that. the patient had a myocarditis and the myocarditis improved to a point that's normal, what are the medications we need to continue? Well, those are factors, obviously, we can discuss for hours about that, but really, in the end, it's going to be a matter of discussion. But in that group, the consensus usually, in general, most of the patients continue with the neurohormonal blockade treatment. Keep in mind what we were discussing about the cause. We are going to be, what is the etiology of heart failure? Is this ischemic heart disease or is non-ischemic? And non-ischemic, there are several causes of non-ischemic heart disease, and this goes to diabetic cardiomyopathy, toxics, myocarditis, peripartum, etc. And you're going to have these slides. But the bottom line is, we're diagnosing heart failure. Diagnosing heart failure is diagnosing a syndrome. We're saying, well, what is the functional class? We're having a stage. We're going to adjust treatment accordingly, but we're going to be mindful in the sense of what is causing this. Okay, what is the cause of this syndrome? Obviously, the syndrome has many etiologies, and we should be thinking about them in order to provide the best outcome possible. We're going to be talking about pharmacotherapy. Heart failure will reduce ejection fraction less or equal to 40%. And really, going back to the same issues, this is a syndrome. There are drugs, for example, diuretics and inotropes. Diuretics can decrease the symptoms and signs of congestion, but they're not going to necessarily improve the outcome. Inotropes, we use inotropes for patients who have advanced heart failure to really palliate the symptoms and as a bridge to another therapy. But we know that isolated inotrope use may increase mortality in patients with heart failure. For example, the chronic use of Myrbetriq, but really we use also as a palliative measure or as a bridge to another therapy, for example, left ventricular assist device of transplant. And we have many drugs here in this category that can decrease morbidity and mortality, and we already discussed briefly in converting enzyme inhibitors, the angiotensin receptor blockers, the ARNIs, basically beta blockers, sinus node modulators. Where these medications work, and really these medications block the main pathways associated with progressions of heart failure. And this is the renin-angiotensin-aldosterone axis and really the sympathetic system. The beta blockers are going to be our main drug to block the sympathetic system. And the renin-angiotensin axis, really we have ACE inhibitors which block the conversion from angiotensin 1 to angiotensin 2. We have the newer combination of angiotensin receptor blocker and neprilysin inhibitors, which basically blocks a part of blocking the angiotensin receptor, they block the neprilysin, and really by doing that we have a dual blockade in terms of angiotensin system and increasing the level of potentially useful natriuretic peptides, just the brain natriuretic peptides, atrial natriuretic peptides that are going to promote the good effects of those molecules which were described earlier. There are drugs, ibrutinib, that works exactly in the sinus node by modulating the heart rate, and we're going to discuss after this. You have a patient with stage C heart failure, which are the drugs that the patient needs to be on, and really they need to be on 2 drugs, okay? And this is the angiotensin converting enzyme inhibitor or, if not tolerated, the angiotensin receptor blocker. For example, the patient has cough, we can use the angiotensin receptor blockers. And a beta blocker. Those are the 2 drugs that have shown highest impact in terms of decreasing mortality. With diuretics, as needed. Obviously, if our patient has symptoms or signs of volume overload, we're going to be using diuretics. For the patients with signs of persistent volume overload, we're going to be titrating our diuretics to try to achieve euvolemia. For patients who are African American and has persistent symptoms, we're going to add a combination of hydralazine isosorbide, dinitrate. For patients who are stable on ACE, on ARB, we will, current guidance recommend to switch them to angiotensin receptor blocker with an angiotensine inhibitor combination. And for patients who are functional class between 2 and 4, have a GFR greater than 30 and the potassium less than 5 milliequivalents per liter, we should add an aldosterone antagonist. And for patients who are on maximally tolerated doses of beta blockers, and still the heart rate is still above 70, we can consider to add abravanine. So this slide really is in a nutshell what you need, how you need to treat your patients and which are the drugs you should be adding in really heart failure will reduce ejection fraction. So now we're going to discuss briefly about these drugs, and we're going to be moving forward. Any questions here? Okay. So the ACE inhibitors and angiotensin receptor blockers really reduce mortality and hospitalization and improve quality of life. They are class 1 level of evidence A. This means that we have multiple clinical trials that support their use, and really those medications should be that's the first medication we should try to start in our patients. And usually when we meet our patients, they are congested, they are vasoconstricted, that's where we usually start. And we have to be careful. Obviously this medication, the ACE inhibitors, can worsen renal function and can cause hypotension and hyperkalemia. So, you know, usually we're going to be titrating every 2 weeks, and we're going to be checking blood pressure, checking basic metabolic panel to assess renal function and potassium levels. The other thing you have to know is that there are potentially severe reactions, basically angioedema, that you have to be mindful, tell the patient the possibility of developing angioedema. And angioedema really is can present in any way, but obviously the most severe way is the way that is related to problems with airway. So the patient should be very mindful about this potential complication. Although it's not frequent, it can be severe. So these are the doses of usually the available angiotensin ACE inhibitors and ARBs. Keep in mind, you should be using any of these. Really, is a class effect, so we are not looking to any particular ACE inhibitors, but I would recommend just familiarize with 1 or 2 of them if you want. Keep in mind which is the initial dose, which is the maximum dose, which is the doses that they have been able to achieve in clinical trials. You know, if you're going to use lisinopril, you're going to start very low, 2.5. You're going to try to target your dose to 40, but maybe you don't get there. And how high you should go, usually you're going to be around, you know, if you get to 30, great, but you should go as long as the blood pressure is stable, as long as the renal function is stable, as long as your potassium is stable. You should keep titrating every 2 weeks to achieve that target dose. Then you have ARBs, and the same recommendation, really work with 1, try to increase to maximum tolerated dose and take it from there. If you have a patient with class 2 and 4, and you know you are able to stabilize the patient, is doing well, one option usually is going to be to you need to, you're thinking, this patient that you have is in your that group that is stable, and you're thinking to switch it to a angiotensin receptor blocker and a neprilysin inhibitor combination. Remember that you have to wait at least 36 hours if you're on an ACE inhibitors, but you can switch to that combination immediately if you are on an ARB. So that's what factors that you keep in mind when you're dealing with these medications. Any questions? Beta blockers, again, like ACE inhibitors, these are the patients have been shown to reduce mortality and hospitalizations, improve quality of life, and they have a class 1, there's benefit, and level A of evidence, and really there are 3 beta blockers that have shown to decrease mortality in patients with heart failure: bisoprolol, carvedilol, and metoprolol succinate. So these are the 3 beta blockers that your patient with heart failure and reduced ejection fraction should be on. This is not a class effect, so we cannot use metoprolol tartrate. We cannot use nebivolol and expect the same outcomes. We cannot use propranolol and expect the same outcomes. So it's really important that your patient be on one of these 3 medications. Remember, the beta bisoprolol and metoprolol are beta selective of beta 1 receptor. Carvedilol, on the other hand, is a non-selective beta blocker, so blocks beta receptors 1 and 2. So if you have a patient who has severe airway asthma or reactive airway disease, I usually try to use either metoprolol or bisoprolol for those patients, just because, as you know, the beta-2 receptor is located in bronchioles and mediates bronchodilation. So be mindful of that. I think it's one of the things you need to know. All the patients with a stable heart failure and reduced ejection fraction should be on these medications. And I highlight the stable because really, if you have a patient that's volume overload, you're thinking of admitting, you're thinking, oh, I'm going to try to uptitrate diuretics to achieve ebulimia and try to normalize the volume status, adding a beta blocker at that time is not the best time to add or increase a beta blocker. If the patient is already on a beta blocker, really, usually we'll keep the same dose and try to manage the congestion with diuretics. Again, these are the medications that you should remember. Usually the initial dose and the maximum dose and the mean doses are achieved in trials, and this is clear in the guidelines. But again, remember which one is the one you want to use. Remember this bisoprolol and metoprolol, beta-1 selective. Carvedilol is not selective for beta blockers, so blocks beta-1 and 2, and for patients with very severe reactive airway disease, this may be a consideration. We're going to be titrating. We're going to see if the patient is tolerate. We're going to be controlling basically the heart rate, blood pressure, and really signs of congestion or decompensation, which can happen sometimes in terms of when you are trying to titrate the beta blocker. And again, the interval to keep in mind, you're going to try to work on titrate the medications every 2 weeks. One of the considerations when you're trying to titrate the beta blockers or initiate beta blockers is there is a period where this is, and this has been shown in nuclear evaluations of left ventricular ejection fraction by nuclear tests. It's basically there's a mild decrease in ejection fraction, and this is going to be in the first between the first 7 and 10 days with a progressive increase in ejection fraction after that time period. And usually you should prevent the patient that they probably are going to feel a little more fatigue initially, but it's really important to try to tolerate this medication to that time period to achieve the desired benefits. Diuretics, really, as we mentioned, they improve the signs of symptoms of heart failure, but they are not linked to decreased morbidity and mortality. There are several classes of diuretics, but the main one that we use really is the loop diuretics. And really, this is the family that we're going to focus. Each diuretics, for example, loop diuretics act in the loop of Hendler, and thiazides diuretics act in the distal convoluted tubule. So they work in different parts of the nephron. And we're going to be using what we call a dynamic diuretic approach in terms of trying to keep the patient the minimum tolerated dose of diuretics to prevent volume overload. A couple of more things about diuretics is that you have to be mindful that there is a potential what we call diuretic resistance, and the diuretic resistance can be related to the inability of diuretic to achieve the same effect and the decreased effect. And there are two things that are usually described. One is post-diuretic sodium retention, and basically that is related to after the increase of natriuresis of the initial loop diuretic dose, there's going to be increased activation of renin-angiotensin system, sympathetic system, leading to progressive increases in sodium retention after the diuretic dose. So one strategy there really is, one is split the doses of diuretics, but very importantly for our patients to keep a low sodium diet that really will prevent that post-diuretic effect in sodium retention. The second thing is what is called the break-in phenomenon. There is a decrease in the effectiveness of diuretics. Usually, if the patient is clinically improving, it means that the amount of extracellular volume has decreased to a point that really these diuretics those high doses of diuretics are no longer needed, and we should decrease it. But there are other signs where there is progressive activation of the neural or moral system. You're going to see a patient that is progressing, increasing volume retention, so you have to figure out what you're going to do. And this usually is, if we're using a loop diuretic, we can think of adding a thiazide diuretic, or and one of the strategies that has been proposed, so loop diuretics include torsemide, bumetanide, furosemide, and we can really add another diuretic, for example, metolazone, another low dose, 2.5, and see where we get with that dose of diuretics. So that's one strategy, add another diuretic to deal with diuretic resistance. Well, obviously, the diuretic resistance is per se a marker of worsening heart failure, and sometimes a parameter that the patient should be evaluated at a hospital emergency department, take it from there. We talk about the sodium diet, and also another important factor is to avoid non-steroidal anti-inflammatory agents that can really worsen and decrease the effectiveness of diuretics. The more we do with diuretics, the more mindful we have to be of monitoring, and really that's what we need to be very careful in terms of monitoring. Like after increasing diuretics, if we are giving, for example, 40 milligrams of furosemide, which is going to be equivalent to 20 milligrams of torsemide, 1 milligram bumetanide. We have to be mindful and try to if we are adjusting the doses of those diuretics, we have to be mindful in the monitoring. Aldosterone antagonists are another important family of medications that have shown to reduce mortality and hospitalizations in heart failure. They are not so potent as diuretics, and really this is an example of medications that have been shown to be great in clinical trials, but when brought to the clinical arena, we have an increased risk of hyperkalemia. So it's really important to be monitoring the potassium levels to avoid hyperkalemia in the patients with aldosterone antagonists. They usually are already on an ACE or an ARB, plus the aldosterone antagonist can lead to serious hyperkalemia. Hydralazine and nitrates, we discussed about the hydralazine and nitrates in terms of the usefulness in patients who are persistently symptomatic and are receiving ACE inhibitors and beta blockers. We should consider these medications, and they're highly underutilized, so it's very important to keep in mind this class of medication for our African American patients. The digoxin is always a controversy, and we will stay out of the controversy. Really, patients with persistent symptoms, in spite of improvement medical therapy, we may consider using the digoxin. There's some epidemiological data linking the digoxin with breast cancer, and we have to be mindful of that. And really, this is kind of not the first drug, but usually we use this medication, we will exhaust other resources. So that's where we are. Really, this is a small summary of pharmacotherapy. And really, if there's a mortality benefit, yes, beta blockers, ACE inhibitors, aldosterone antagonists, hydralazine nitrates in African Americans. And those are the medications we are going to be looking to improve outcomes. And basically, we're going to be increasing using diuretics to treat the symptoms of our patients, and we are going to be monitoring for the potential toxicity of the diuretics. We're going to be talking about two medications. Very briefly, I have a bunch of slides of these two medications, but we're going to be very briefly. Basically, angiotensin receptor inhibitor is a new medication, has been approved for a stable patient with heart failure, reduced ejection fraction, who are stable on ACE and ARB. We should consider switching them to ARNI. I think most of the providers are familiar with this drug, which is kind of the last drug that we added to our armamentarium. And the effects we already discussed a little bit, and basically blocking the angiotensin receptor, renin-angiotensin aldosterone system, and basically increasing the levels of natriuretic peptides. These are the effects of natriuresis, and really the effects of the neprilysin inhibition. So the main issue here is that this medication, when compared with enalapril in a dose that was equivalent to a clinical trials, has been superior from an endpoint, a composite endpoint of death from cardiovascular causes and hospitalization for heart failure. And this is the number needed to treat, which is fairly small. And really, this is the number needed to treat to avoid one death from cardiovascular causes, which is pretty small. So we're not going to be reviewing other, terms of number needed to treat, but it's just to put this medication into context, and really is equivalent to other important medications that we have discussed before. But the number needed to treat okay, when we compare the ARNI, the combination with the other ones, still higher. So remember, these are the drugs where we should be focusing first, therefore, to achieve the stable patient with systolic heart failure. And these new medications should be considered in the appropriate context when added to these patients. If we have a patient with asymptomatic ventricular dysfunction, we will say New York Heart Association class 1. Really, this does not meet the usual inclusion criteria of the trial. So keep in mind this important medication improvement compared with enalapril, and really current guidelines recommend switching our patients who are stable. But if we have issues in terms of being able to get this medication in terms of insurance or in terms of cost, the other medications should be continued, and really they are very good options for our patients. And the last medication really is, this is kind of the dosing and how they're going to tolerate, and you're going to have these slides. Remember, we have to wait before we start these medications in patients who are taking ACE inhibitors. We usually start slow, and these medications usually they have an effect. They can cause hypotension. We have to be mindful of that and try to start lower dose. But obviously, this is an ACE inhibitor, and we should be able to really accommodate what we need in terms of how the patient is going to be able to tolerate, in terms of how much ACE inhibitor or ARB the patient was using before starting the combination. And these are our slides that basically are talking about the different doses, and are going to be available for you in the web. This is, remember, the 36-hour washout. And the side effects really is going to be the hypotension, increasing renal dysfunction, potassium, cough, angioedema. These are the main things, and the adverse effects are similar to the ACE inhibitors, okay? I'm going to, in the interest of time, I'm going to try to go fast in these medications, where are the new medications, and then for patients who are on optimal medical therapy and maximal tolerated beta blockers, and they still have a heart rate that is above 70, we should consider the addition of bravadine. And this again have shown to decrease the primary endpoint, which was a combined endpoint of hospitalizations for heart failure. This medication also has shown to increase the quality of life and improve basically hospitalization, quality of life, and decrease in neural function class. So there's no mortality benefit, but decreased hospitalization. So it's something to consider when you have a heart rate after titrating beta blockers to the maximum tolerated doses. These are the adverse effects, which generally is very well tolerated. You can have bradycardia. This is kind of one of the main things. Remember, this can increase the risk of atrial fibrillation, and really, this is the most important thing. The channel that is blocking the sinus node is located in the retina, so you can have some phosphins and vision stuff that's something not so infrequent, unless I happen to have patients that have referred this. So these are the target population, really heart failure, reduced ejection fraction, and with a heart rate that's greater than 70, we already discussed, and also already on maximal tolerated medical therapy.
So Dr. Alvarez, we're hitting our hour here. Actually, we're a little bit over.
Yes.
Shall we?
So I'm going to finish in two things, okay?
Okay, perfect.
So basically, we finished the pharmacotherapy section, and really the last thing I wanted to talk is the advanced heart failure. I want to refer, that's going to be very brief, but if you have a patient with severe symptoms, multiple hospitalization, this is spite of being able to achieve optimal medical therapy, you should start considering this patient to be referred to a center with advanced heart failure therapies. This is transplant, left ventricular assist device, or really the other options, teams related to palliative care. So basically, keep in mind a patient who has multiple hospitalizations for heart failure, increased risk of dying. The patient that you are not able to titrate ACE inhibitors because develops renal dysfunction, be mindful that that may be a manifestation of advanced heart failure. If the patient is not able to tolerate titration of beta blockers because of the compensation, is a patient with advanced heart failure. So those are the patients that are increased risk of dying. And the last thing is being aware that there's scores in the internet where you can go to a Seattle heart failure model, and it's going to help to predict the outcome of your patients when you put in the information about demographics, background medical therapy, and some very simple blood work. You can get a really good sense of what is going to be the mortality of your patient. And by doing that, you're going to help in risk stratification and timely refer to advanced heart failure center. With this, I will finish, and I thank you, and that's it.
Well, thank you so much, Dr. Alvarez. And we have recorded this. You have all those slides on there. I know you didn't get to all of your slides on medications, but we will certainly send those out. And this is going to be a fantastic resource to our primary care providers out there who are treating heart failure. So we appreciate your time today. I know you've got to go hop on the plane, don't you?
I have, but it's fine. That's not the stressing part. We have many complicated patients, so that's where we are. But it has been a pleasure, and I hope this helps. And obviously, I'm available for any questions by email. Feel free to share my.
We have one quick question in terms of where does cardiac rehab fit in with a heart failure patient?
Yes. So cardiac rehab is indicated. So that's a very good question. Cardiac rehab is an essential component of treatment. The issue we have is I would recommend it to every patient with symptomatic heart failure who is stable on medications, who has been optimized in medications, or really there are no signs of congestion or anything that is evident that will limit the exercise capacity. Really, I refer to cardiac rehabilitation. We have an issue there in terms of insurance issues, and the Medicare has established a very good coverage for patients with heart failure with reduced ejection fraction, and those patients usually the pathway of referral is very easy, and we have a very good cardiac rehab center here in River Landing, now University of Iowa River Landing. I know I'm aware because I have patients in many parts of Iowa and Mercy. Point. So there are many centers, but really what the problem comes for the heart failure with preserved ejection fraction, really we struggle to refer them regarding insurance. Cardiac rehabilitation is not only really to do exercise, to be able to achieve like a time in the treadmill or on the bike, but also it's a comprehensive assessment on lifestyle factors such as diet, blood pressure monitoring, and other resources that help us to weight loss, which really help us to control our patients and really improve dramatically the quality of life. The largest trial with Action HF really didn't achieve a primary endpoint result, but really it's also true that these patients have a big impact in improvement in quality of life, and really that's, I think, is indicated for all these patients. It's clear?
That's great. Okay. Well, we appreciate your time today and taking your time away from your clinic. I know that's not an easy thing to do.
Yeah.
again, I'll get the slides out to everybody, and we'll get, if any questions come to me, I'll contact you, and we'll get those questions answered.
Perfect. Great.
All right.
Thank you very much.
Well, thank you. You have a great day.
You too. Take care.
And thanks to everybody else for joining us today. You have a great weekend too. Bye-bye.